Hello, good morning, everyone, and welcome back to the Vitrolife Group Academy studio. So today is my pleasure to introduce you Dr. Julio Martin, that is my colleague and friend, who is going to talk about career screening. So Julio, please, whenever you want, the floor is
Okay,
yours.
thank you. Thank you. Hello, everyone. My pleasure to be here and to talk about career screening. And when we talk about career screening, we are in the context of health prevention. We want to prevent Mendelian conditions for the offspring. And what about Mendelian conditions? They are single gene disorders that can be inherited in different Mendelian patterns, like the dominant, recessive, and X-linked. But they are individually rare, not frequent. But when we combine all of them, indeed, there is a high impact in the society. There are different sources indicating the prevalence of these conditions. And as you can see here, clinically, they impact significantly regarding the admissions in pediatrics hospitals and also in infantile mortality. So there is indeed a need to identify the risk, and optimally in a preconceptional scenario, although it can be done also in prenatal. So to put clear these figures, the Mendelian conditions are rare regarding the incidence or the prevalence of them, but regarding carrier frequency, they are quite high for many, many conditions, like you see here in the table for some of them. And this is accumulative independently. So at the end, we have to keep in mind the concept that almost everyone is carrier of one of these type of diseases. It doesn't mean that the carrier will show a phenotype, but when combined, it can be a risk for the offspring. So what is the precise aim of a carrier screening test? The aim is to identify heterozygous carriers for recessive and X-linked conditions in women. And with that information, we have to combine in the male and female gamete that information to understand if there is high risk for the couple. We call that DNA match. Once we have that information, we can manage by informing the couples about the risk, and they can take options to do PTM or gamete donation. The field is not new, so that means that carrier screening has been done for decades indeed, in particular started in high-risk ethnicities, and there are guidelines indicating or recommending to follow this type of testing. As just the last ACMG recommendation in 2021, they established a tier-based system, and outside high-risk populations, the recommendation is to go for tier 3 with a minimum list of genes about 130 conditions indeed, precisely. But also the possibility of doing tier 4, that is a higher number of genes, always giving information about the limitations and benefits of testing that quantity of genes. So, one key concept that we should keep in mind at the end of this practice result is that the ACMG Professional College recommends to offer this type of test to every woman pregnant or considering pregnancy. Well, now I think it is important to understand what is the offering of this type of tests. And what we see, very briefly, is that the offer is fragmented. I mean that there are different providers offering different gene content in their carrier tests. So at the end, we have to remember that what we want is to combine the information in male and female. So this fragmented market may impact or limit the matching, the comparison of the data, because we all know that IVF patients move from one clinic to the other, and maybe one clinic use test one and the other use test two, or a bank with donors decided to use the test number 3 with all of them different quantity of genes. So at the end, making a limitation in the DNA match, as you can see here in the slide. We took all this information in the market and we realized that there was a solution in our hands to offer a carrier test trying to solve those limitations. So as a summary, our tests are based in exome sequencing, and we also use a complementary test in order to call complex variants. The use of exome has many benefits. I just want to reinforce the message that we can test almost any gene that has an association with a phenotype. And also it's important to understand that we can customize the gene content for the test that we offer. And there is no need for new resequencing when the exome is the methodology used for the CET, for the carrier screening. Also, it is important to add that we can upgrade, so we can decide what to report, maybe a closed list of genes, but we can upgrade that number of genes if it's required. An image that maybe summarize this is like if you have two tests and one of them has exome-based carrier screening and the other is a closed panel, regardless that you maybe don't report it initially a given number of genes, you still have that information in the exome. So we can recover that information, that we call that upgrade, and then do the matching for that couple. It's an advantage of using an exome-based carrier screening as Igenomix is doing. Let's put an example. For example, imagine that there is a bank of donors that use an exome-based carrier screening test, and you report a number of genes initially for that bank, and then you need to match with a patient that is positive. It has any type of test, is positive for a given gene. So maybe the gene was initially reported, and you can look for that in the report and offer the matching. But if it was not reported initially, we can still make an upgrade, recover that information from the raw data that we already sequenced, and update the report, and in that way we can match the information in the patient. So at the end, having the exome-based carrier screening is a perfect solution in order to offer matching and provide the information needed for all the couples to understand their reproductive risk. This is our main portfolio. We have different type of panels offered to banks or to patients. But again, since we have the exome and we are sequencing all the genes in the genome, we can recover that and offer particular tests like the CET1 or personalized version, customized. We can add as much as needed based on the request of the clinic or the patient because of the family history or whatever. For example, if there is one test in the market that offer a definite list of genes, we can mirror that panel in order to keep the service going in the market for already tested patients or donors. Just to finalize the explanation, we want to reinforce also that we have a platform that can be offered to our customers in order for themselves doing the matching with for their patients as needed. Take-home message regarding the carrier screening offered by Vitrolife Group is we use exome sequence to report our CGTs, carrier screening tests. We defined our gene content following the clinical significance, the test compatibility against different tests in the market, and also obviously following the professional college recommendations. So at the end, our test provides universal matching, allowing us to not only our main panels, but also offering personalized versions or giving the option to upgrade all of our tests. Thank you for your attention.
Thank you very much, Julio. Fantastic presentation as always. Is there any question? So, Julio, we are always thinking in reproductive medicine in our field in IVF, but do you think that this test is for everyone? I mean, we are thinking always in egg donation, but don't you think that this is for everyone because we all have the same percentage of mutations, right?
Right, totally true. I agree. This type of tests indeed are universal. Any couple that is considering, any woman considering pregnancy, this type of tests apply to them also. Doesn't matter if they have fertility issues or not, because at the end, the Mendelian conditions, the prevalence is in the population, not particularly in the infertile patients.
And it's not changing with the age of the patient, right? Like
No, not changing. It's not like the chromosome aneuploidies at all. No, that's true.
Okay. So thank you very much, Julio, and
My
see you in
pleasure.
the next session. Thank you.
Bye.